say that's right.
Hi, I'm Tim Carey. I'm Director of the Shep Center for Health Services Research here at UNC. I want to thank you all for coming and welcome to the 2015 DeFriese Lecture. The Shep Center for Health Services Research was founded in 1968, which, if my math is right, puts us in our 47th year. Shep Center is one of the oldest and largest academically based health services research centers in the U.S. We collaborate with faculty from across campus and across the country on projects ranging from systematic reviews to intervention studies. Our work informs healthcare and health policy not only in our own state of North Carolina, but also around the nation. The DeFriese Lecture is named in honor of our own Dr. DeFriese, Director of the Shep Center for 27 years, an amazing legacy, and one which I can guarantee will not be repeated in its speaking person. Gordon is with us today, and I want to thank him again for his leadership and support. Thank you. The DeFriese Lecture is our primary named lecture series, and we invite national leaders to challenge us regarding future directions for our work as we need to be challenged. Although UNC and the Shep Center are long-standing and very established organizations, healthcare in our state and the country is again undergoing rapid change, and when has it not undergone rapid change? Our work must change as well if we're going to provide the best guidance to healthcare providers, the public, and the policymakers. Dr. Tom Ricketts is our lecturer this year. A Moorhead Scholar and graduate of UNC, Tom Ricketts has worked at the Shep Center since 1978, which I think was the Carter administration, and was already established as the go-to person on issues of health workforce policy when I arrived at UNC in the early 1980s. After completing his doctorate in health policy at the Gilling School of Public Health in the 80s, he has continued to work in an amazing variety of areas, including small area variations in care, rural healthcare policy, and health workforce policy, becoming a leader in each of those areas in the university, in the state, and nationally. His book on medical geography has informed generations of learners and policymakers, as well as over 120 peer-reviewed publications, serving as PI on many grants and contracts, including multiple center grants. Tom has served on national and international advisory committees to the program and collaborated with legislators and their staff at both the state and federal levels to directly inform health policy. Tom has been a sought-after professor and an outstanding mentor for graduate students, postdocs, and faculty. I never go by his office when there isn't somebody sitting in that chair talking to Tom and learning about everything from disease management to health workforce to SARM caregiver. He and his work have influenced generations of researchers and policymakers. I'm delighted to introduce Tom as this year's DeFriese Lecturer. Join me in welcoming him. He'll be talking about translating research into action, and there's no one better qualified to address how we as health services researchers can ensure that our work makes a difference in society. Thanks, Tom. We'll have time for questions after the talk, and we'll have some questions as well.
Well, it's a great thing to have you all here, not for the fact that you're inside when it's so nice out and hasn't been so nice. It's a real tribute to myself and the board of DeFriese. Thank you very much for coming inside on a wonderful day. I want to thank the lecture committee and Tim Carey for giving me the chance to follow a long list of very distinguished lecturers. It's really an honor to be listed in that list. I mean, it's a fantastic honor. It's truly a big deal to stand here and honor Gordon DeFriese and his truly exceptional contributions to health services research and to the University of North Carolina. I'm hoping to use this presentation to sum up a little of what I've done in the past, but also to reflect on some issues that were raised by Gordon in the past, and then to talk a little bit about things that we might need to do in the near future, like tomorrow. But I'd like to give you a sense of where I come from prior to the Shep Center. Most of you know that I came to UNC as an undergraduate, and in the building right next door, the first thing I did when I came to UNC was go from my dorm to Keenan Fieldhouse and change into a light blue uniform, which turned to a bloody red brown afterwards because I was on the freshman team, which was, I learned what the scout team was, and I was beaten up on a regular basis by some people, until I quit and took up a more genteel sport, which was rugby. I got through college with a degree in history and Russian, and one of my professors, Will Brooks, who taught me as an undergraduate this year, taught me Russian intellectual history. And if you think, I dropped the Soren Kierkegaard part, but Lomonosov, I can go on for that for a long time. So if you see Will and I talking, that's what we're talking about. But I got out of the UNC, did a few odd jobs, and then almost by chance, I went to work in Washington for Taylor Branch. I don't know if you know Taylor Branch, you ought to know him. He's a Pulitzer Prize winner. He made that happen, gave me a job at the Washington Monthly, and he brought me in touch with a whole lot of people who were very important. I was just a young kid. I didn't realize who these people were until I drove William Westmoreland down to Norfolk one day. Couldn't figure out what that was all about. And played tennis with Creighton Abrams and things like that. I don't know what was going on, but Taylor had connections all around on both sides. And so I spent a little time watching people do things in the Senate, which was very interesting. And literally ran into Richard Nixon in the Senate elevator, which I learned some of the chokeholds that the Secret Service had. But Taylor taught me to reflect on the really important things and to look at the national stream of things, and that was very nice. But I drifted back to North Carolina and got a job working with Livonia Allison. And Livonia Allison was also someone. Here's Livonia, and there's Taylor. Taylor and his band in our fraternity. We were at a time when music and revolution were really important. But Livonia Allison taught me about that there were a lot of things happening in Raleigh. And she gave me, as I worked for the Health Manpower Development Program, she gave me a point of view and an understanding of the streams of policy and the streams of politics and how things needed to change to do what she wanted to do, which was to bring African Americans into health professions. And that wasn't an easy thing that needed to be done. But while I was working for Livonia, I was over in the Little Professor bookshop, if any of you remember that, over in University Square, ran into a guy with a goatee. Interesting guy. Said for some reason we started a conversation, and I said I work for Livonia Allison. He said I set up that program, along with every other program that you think is worthwhile. And he listened to what I was doing. That was, of course, Cecil Shepps. And Cecil basically said, you ought to get an MPH. You ought to learn what you're doing. So then I did, and I said, well, I'm going to try and get an MPH and extend some of the things I'm doing. And as I got into the MPH program, I met a guy named Jim Bernstein. And Jim Bernstein, he talked with me about, we were up at the Prospective Payment Advisory Commission. Jim was a member of the PROPAC at the time. And basically he said, what are we doing up here in Washington? We'll never get anything done in this thing, this PROPAC committee. Go back to North Carolina where I'm working and stick around there and you get something done. So really, that's why I'm here. That's the where and the why of the journalistic story. But it's the what and the how that are yet to be determined. And they were determined by an interesting cast of characters. Somebody who probably you don't know is Stephen Farrow. Stephen Farrow was my first advisor. He was a physician, English physician. My first advisor was a really interesting guy, dedicated to public health, was essentially the health director for London and then for Wales. Very gifted person, but he was working with then the VA in Fayetteville. So here I try and get out of Fayetteville all my life, Fayetteville where I graduated from high school, and then back in Fayetteville at the VA. And we were doing something called health services research, which I thought was an interesting thing. Wasn't quite sure what that was. But Stephen got me connected with people in Washington, and then I began to write some testimony for a guy named Max Cleland, who was then the chief administrator. Now they call it the secretary of Veterans Affairs. But Stephen invited Gordon DeFriese down to Fayetteville to tell us about the new health services research centers that were being set up throughout the United States, and he was leading one of them. And it was a fascinating presentation, because it was very clear that the field was just being created. But it was very clear that Gordon had an idea where the field was going, and he was going to make it happen. And I said, well, this is somebody I ought to follow on, because this is something new, and I can learn a lot, and I can get right up there in the front line. So Stephen introduced me to Gordon said, why don't you come on and we'll put you up and play maybe a carol in the library in Chase Hall. And I had a job with no job description, but a sense that I could do just about anything I wanted to. And a man who ran the center, who basically let you as long as it didn't hurt anybody, and really was doing some good for the country. These people at the time, there was a term when primary care was going around a lot. And Harvey Estes and Don Madison were really creating what primary care was in a government sense, in a professional sense. And there was Glenn Wilson. He had an idea of what primary care was, and not necessarily the same as anyone else, but Glenn was really, a very stimulating guy who was really helping out. And so these were my mentors. But then there was also Dan Beecham, who took on the job of being my PhD. Eventually they said, well, you need to get a PhD. And Dan Beecham said, well, okay, why don't you, I'll be your advisor, and let's talk about politics. And Dan could talk about politics. And in fact, he was so frustrated at teaching politics, he went and became a politician and was mayor of Bisbee, Arizona for a while, where he still lives. And we stay in touch. But Dan Beecham, Arnold Paluzzi was the head of the doctoral program, and I learned a lot from him. And while I was doing a dissertation on rural primary care, he taught me about something called CCOP and community clinical oncology programs, and I was on the road doing research in that. So that was really another dimension, because I was writing a dissertation about rural primary care, going all over the F part of America. I don't know if you know what the F part is. Since we were doing a rural, an assessment, you'd think that would be frontier. But no, the F part is the places we flew in for rural clinics, and they were Fargo, Fresno, Flagstaff, Fayetteville, Arkansas, and Farmington, New Mexico. I began to hate it when somebody said, going to an F airport. Okay, well, but that's what rural, that was part of it. You flew to places nobody else flew in, or you didn't think they were. Arnold Paluzzi taught me a lot about things that were, theoretical in nature about organizations, but he was also a practical person, and he had helped develop some primary care centers and clinics across North Carolina. Bob Conrad really helped me with the theoretic part. I can't go without mentioning Bob, and I can't go out without mentioning Jane Stein and her skills. They set up, one of the things the Shep Center had that other people didn't have was an actual computer. Really, 1979, a computer of your own, and I'm not talking about a trash 80, I'm talking about a mini that did things. And they really, we computerized the health workforce data in North Carolina, and initially the hospital discharge data. We did some great things. So it was very, it was a fecund, to use another F word, a fecund environment, and one was able to grow very rapidly there. In the late 1970s, there was a lot of enthusiasm because we had changed the system to create the specialty of family medicine, fund and establish community health centers, sharpen Medicare's focus, create rural health initiatives to increase access. All of these things were done by these people that I was meeting. But there was a good question of how what was done was done. How did you make those things happen? Because there was a lot that needed to happen, and people were beginning to meet some resistance. So the question began, okay, how do we overcome the resistance to expanding what we know? Now nowadays we call this implementation science. And that, in the old days you'd call that psychology, in a way, behavioral psychology, behavioral economics, or community psychology. But now we call it implementation science, which is a big thing here in Chapel Hill. And Brian Weiner leads some programs at the Shep Center and over at Health Policy Management. The Lineberger Center does great things about it. But this problem of implementation, or getting people to do something, is a difficult thing. And I want to ask the question, really, how do you overcome resistance to change? Not so much as how you make change happen, because I see resistance every day. So I'm going to pose some difficult questions, and I'm told when you're posing difficult questions, having people think you want them to be sympathetic to your message. that we want you to be susceptible to the things I'm going to say so that you feel better afterwards, even if you don't learn anything. So I'm wanting to, we're talking about change. We're talking about getting people to change things. And we want to see if we can really, duplicate the progress we've made way back when. So here's that sympathetic part. This is my grandson. He's going to be here later tonight. And so I just want you to get in a mood of receptivity. Believe me, you will do anything he asks. Okay? And if you don't take my argument seriously, and if you don't, I can hit you really hard with the next thing to really make you soften you up, and that's the puppy. This is my dog. When somebody brings out the puppy, you know you're going to have a really rough go here. There are going to be some things you might not agree with. Here's an actual manager of a clinical system undergoing change. It's a really difficult thing to do. Changing people is difficult. This gives you an idea of the challenge. The puppy gets you in a good mood. This tells you what reality is. Change is not easy. Change does a lot of things. I think the originator of the notion of disruptive creation or disruptive innovation is Alfred North Whitehead. And basically, he said that, you wreck things when you do change. You wreck societies when you have real change. Now, we don't necessarily do that in health policy, but we have. When you look at things like Medicare, we've done some things that we didn't anticipate. We were going to just, help people who, were employed, and we were going to give them some, they've been to work, and then in their old age, we were going to take care of their modest health needs. But what we did was, we did a lot of other things, inflation, things of that nature. So I'm not going to talk about necessarily the big things, but I'll put you in mind that change is not always good. Change doesn't necessarily bring the right thing. But I'm going to talk about smaller scale changes. Although we're living in a time when there are some really big things happening, changes in the air. We have these things called ACOs. We have value-based, value-based updates, something I'm working with for the American College of Surgeons. We have a value-based workforce, that's an idea. But value-based, but what is value-based? How are we changing things to make things value-based? Because even people in the White House call it Obamacare now, we have Obamacare, shifts and surprises and things like that. So change, people might be confronted by a big change depending on what the Supreme Court does. But we also find that there are little things in Obamacare that we didn't know really what we were doing. And so that will change things. But we're also having mergers. And we're having bigger is better mentality. And that bigger is better mentality is very interesting because it comes in many, many forms. And I want to talk about this notion of change toward bigger, because I think change toward bigger is something that is not just big, I call it aggregation. It isn't regionalization. It isn't centralization. It's kind of a mix of this centralization and market concentration with a kind of institutional rationalization. Now the bigger, who's doing them. You open up the paper to find out what small rural hospital is part of UNC today. And it's almost like that. I mean, people in the C-suite seem to do that. But what is happening is people think bigger is better because it gives them predictability. It gives them predictability in payments and costs. They see safety in size. Now, Bob Hurley was able to kind of put this in two dimensions. There's vertical integration across the scope of services, and then there's horizontal integration. But we're doing these all at the same time. But we're doing them in some ways, especially to focus on specific clinical structure. So you can find a horizontally, vertically integrated system that wants to just deal with knee replacements. And so we're getting focus factories that are trying to really aggregate things, but they're becoming bigger and bigger as they create change. But we're also having large general, like those things led by UNC, that are horizontally integrating, vertically integrating, and setting up multiple series of product line structures. Now that's something that takes a little while to think about and to think about how you're going to change people to work in that. And I'll talk about that a little bit more. But in this process, we've got to change some of the policies to make these things happen. We've got to cope with these new things. Remember the dog, and I want to keep you receptive here. Like Google, yes. So we got to do policy to accommodate these changes. And we are the keepers of numbers in the research side, so we should be able to tell people something about how this change is affecting them and what we ought to do with changes. And we do this with science. We're, like I said, the keepers of numbers, the manipulators of numbers. And so we do three kinds of things to really tell people what to do. And it's important to remember these same three things all together. They include research. Okay, research, very high, peer review, high standards, that sort of thing. But we also do policy analysis. And now the rules for policy analysis are, it's okay to copy as long as you attribute. Policy analysis from the RAND institution or from Brookings is a little bit better than policy analysis from the Southwest Center for Democratic Processes. But it's still the same sort of thing. People are using even regressions in their policy analysis. They're using statistics, they're using data. They're trying to make the case that comes from probably the original numbers developed in research, trying to make them applicable, but then how to apply them is done by people who do advocacy. Now, we all do advocacy, whether we know it or not. But we also find ourselves sometimes doing advocacy and then somebody on the other side doing advocacy against us using some of the same data. Fascinating. And that's because of Newton's third law of health services research. For every PhD, there's an equal and opposite PhD. Now, the assumption that there's just one science that lies behind the research and policy analysis and in turn informs the policy process is very much wrong. Not only is it wrong that there are equal and opposite PhDs, but now the opposite PhDs can get funded by just about any kind of random think tank. So the equal and opposite PhD process is going on in the public policy sphere as well as the scientific debate sphere in a way that's making people, a little bit weary of the scientific debate and a little leery of the conclusions of people who call themselves scientists. We have to cope within that environment. Let's talk ACOs. The idea of ACOs came more or less a theoretical proposal based on observation of various practices and a lot of good intentions and the promise of scaling up those things. But how do you make people at an ACO? How do you make them work at an ACO? How do you make things happen so that people will do what an ACO wants to do? Now, we have this thing called the triple aim, quality, population, health, costs, and things like that. Well, I contend we have a problem with aim training. Now, it's one thing to say we want quality care, we want lower costs, we want great population health. It's another thing to tell the person who's working all day long that that's what their job is. We're having trouble with trickling down the triple aim notions. In short, aims may not trickle down, just like a lot of economics we had, to the folks who are working in the trenches, because it isn't that they don't want to change, it's just they want a little predictability in their lives. Now, changing for good, we're all assuming that the change we're proposing is change for good. So we talk about things in a very positive way. Steve Shortell talks about theories of action. Action is good. Doing stuff is good. Making things good. But it's sometimes, and this is Mr. Grumpy, that's me, what about the negative? What about this thing about, resistance to change? How do you understand that? How do you know when there's a bad change coming, what to do? Well, I want to talk about that. Here's a picture of a theory of change from Brian Weiner. I thank him for this. And let's say the inclination of looking at negative change came from this little box up here. It says change valence. To me, valence was the plus or minus of an ion or a molecule or something. I was going, well, if there's positive change, there might be negative change. Let's think about that, and where might negative change be useful to us, or understanding it would be useful to either promote change or thwart change if the change is bad. Well, you might want to talk about turning bad changes into good changes. So I created something called dissemination science. Dissemination with a Y, as opposed to the I. And this is a study of the resistance to change. Now, you might think, well, that's a cool thing to think about. Well, somebody's already done it. His name is Albert Hirschman. Really nice guy, an economist. I'm sure some people have heard of him, things like that. And he was he did work on what were called micro-choices. Now, everybody knows that's behavioral economics. People have written books about it. But he was the first guy who really did this. And he wrote a thing called Eggs, Voice, and Loyalty. It was excerpted in the Washington Monthly, of all things. I read it there. Thinking about, how would this affect my life later on? But it was amazing that I began to see this notion of what Eggs, Voice, and Loyalty were all about. It was how people respond to bad institutions or bad structures. We put it in the Washington Monthly then, or Charles Peters did, as the editor, because he wanted to try and understand how people were reacting to the Vietnam War. They were leaving, they were shutting up, or they were complaining. But the more important book that he wrote was The Rhetoric Reaction. It came out in '91. Oh, Albert Hirschman, he died. I'm sorry, you can't visit him now. He died in 2012. There's a great essay about him, Malcolm Gladwell did, The New Yorker in June 2013. I recommend that essay to you. But Hirschman's dissemination came up with 3 theses. The perversity thesis, the futility thesis, the jeopardy thesis. Now, these were initially suggested by Hirschman as a way to counter the conservatives, counter-conservatives, who were using this as what he called the rhetoric reaction. In other words, how do you argue against progressive change? But as a student pointed this out to me, well, gee whiz, we can do that too as conservatives about your silly changes. And I said, well, that's true. Of course you can. But you have to think about this, this is a universal double-edged sword that can be used in many ways. And so I'm going to focus on that a little bit. Let's talk about perversity and medical homes. I'm not saying they're perverse. I'm just saying that they are a change that most people in this room would see as an unalloyed good. But some see it as perhaps the wrong way to go. How do you counter these arguments? Now, they might seem silly to you, but they're real. Get them off of the way up. Of course, you can get anything wrong. But how do you take these arguments, recognize them for what they are, and then turn them either on their head or refute them? How do you deal with this problem of perversity? How do you deal with the problem of futility when people argue against medical homes? We see this as a form of, say, social engineering is going to be futile in a real world. How do you deal with people who are talking about jeopardy? I mean, we call medical homes truly experiments. Experiments, as we all know from Frankenstein, can go bad. So how do we tell people that, no, this isn't going to put you in jeopardy, it's going to put you on the road to progress? Now, this notion of jeopardy, I'll give you a little idea of what jeopardy, my view of how we're getting into jeopardy on something called ACOs by this little picture. Now, this picture might seem, wow, this is good, the patient is at the center. That's good. Well, we've got patient-centered stuff, we've done bundled payments, we're coordinating care, things are great. Okay? Well, but there's a complex, this is complex. This is the people who have to be engaged, in a complex, multi-problem patient. You've got to deal with all of those folks. But we've got ACOs, and ACOs are doing a wonderful thing. They are creating this kind of coordinated system structure for, say, somebody who has, say cancer or stroke or whatever like that. And that's great. But then that has to coordinate with that other system, that's doing chronic care management or dealing with, other aspects of end-of-life care. So, and voila! That's French for R squared, but I just turned it off. Voila. Okay, now we'll jump in. Okay, you ready? Okay, voila! Very good. Now, this complexity is what I consider the jeopardy aspect of ACOs, and we really haven't had people tell us how we're going to deal with this complexity other than cell phones. But this is fantastic. We could do that. I could see somebody in the room. There's a graduate student hopefully taking notes. And I think if you create a Google app that basically hovers over this thing and comes up with a story of interaction and how it can be solved and the problems and challenges, that might make a great dissertation. Are apps, are they eligible for dissertation? No, but we could. Okay. Well, faced with this kind of complexity, people are stuck with Hirschman's options. But the thing is that if we think about that jeopardy thing about the organization, we're beginning to forget a little bit about the people who have to work inside of these systems that we anthropomorphize into giants or 800-pound gorillas, or that we're just minnows swimming in an ocean of sharks. Because in this process of change, the people are having to make a real, they're having to make decisions of their own. But we're spending a lot of time talking about the medical home system, integrated care, ACOs and things like that. And we're really fascinated by the character of the collective as opposed to the welfare of the person working in that collective. Because those people, they have the chance to really, they can take this kind of modification and change and say, okay, well, I'll knuckle under, I'll be loyal, well, I'll complain a bit, I'll have my voice, or I can be exit. So we have to think about how that process can be overcome so that people can contribute to the system. Now, for those younger, the graduate students, so people younger, let me translate this. You can befriend somebody, you can share, or you can like, and you can put a little emoji with it if you really like it. But this process of, let's say, understanding resistance and how to overcome resistance, and the level of resistance is, I think, the next challenge for really what we ought to be doing in implementation science on a practical level, on the policy level, not just on the organizational sociological level. Okay, let me change direction here. Okay. I'll pause, because there was a big question I had years ago when we were working on this, starting in the 1970s. My dissertation was, of course, about primary care, which I'll bore you with if you want me to, but I started working in primary care, and I want to review lately what has happened to primary care after I worked on a dissertation, or, as an undergraduate, first graduate student, MPH, and then did a dissertation on it. We did a lot of work, but the question is, did we really get people to change based on the things we did? And what has happened to primary care if we did get people to change? What has happened? So I found an old survey that I did, or the center did. It was from some work that started by Harvey Estes. Harvey Estes led an IOM committee on what is primary care. And Gordon DeFriese said, yeah, we need to study what's happening in North Carolina with primary care, because he had done some work many years before about some primary care doctors. And basically we said, well, we're going to find out what, primary care is, the primary care definition study in North Carolina. But then I found one that just left on my desk last month in Health Affairs about a study of medical home processes. Basically said, let's see whether people are actually doing primary care. So it was interesting. Folks in the 70s and early 80s were worried about access, continuity, and comprehensiveness. But you can see that they're doing different approaches to this. They're concerned about different things. And I think somehow we've really moved away from this access stuff, because the things we're worried about, we don't worry about whether you see Medicaid, we just assume you do. We don't worry about whether people have, whether you can get into the place during working hours or outside of working hours. We just assume you can. Now, is that true? Now, there are similarities from the decades apart paradigms. Really, since, yeah, you got to look at records. But nowadays, we can look at records through EMR, changes in technology. But there's this other part where, we've done a lot of different new things. Patient feedback. Nobody cared about that then. I mean, there's a little bit. You're supposed to be a good person, but don't listen to what they say. You can hear what. Group visits, we didn't have that. That was collective medicine was unheard of. And this electronic health record, of course, didn't exist. Essentially, the view of, do you do primary care was encompassed in this one question. You act as the primary care provider, of course you know what that is. And then they defined it later on, because We needed a definition, did a lot of definition. But interestingly, both of the studies found that of the practices that they asked, folks did about 20 to 30% of the things that were supposed to be good primary care. Then and now. It's fascinating. I mean, is it that medical homes are a continuing implementation of the implementation we were doing back then? And are we going to just get around to another cycle of, well, we can't implement this, so let's redefine things, which is what happened in '78. We had two separate and sequential definitions of primary care come up. So I'm still not sure whether we've really made a lot of progress in primary care in terms of doing what we think we ought to be doing, or the researchers are asking the wrong questions. Okay, well, that's the organizations. Let's talk about the docs. There is a big change in what's happening in what the medical role and what physicians are doing. In the old days, you knew what you were doing because you were a specialist and you did what those specialists did in that specialty. But now you do things that are focused on what you do in an organization or a relationship to an institution. And this process is not necessarily focusing us to do things better, it's making things a little bit more complicated. Because we're entering this world of hyper-specialization that doesn't necessarily mean that we've expanded the internal medicine programs to infinite divisions. We've just taken those internal medicine trained physicians and decided that we will break them up into infinite organizational divisions. And so that we have now these hospitalists and proceduralists and things like that. We have 315 specialties listed in the AMA options of what you can click off on their list. The specialization might create the opportunity for industrialization of medicine. And I show it just to scare people. This is the opposite of the puppy. We're creating focus factories where everybody has a job. You get the gizzard, you get the wing. Okay? In the doctor world, but we have them not only in the specialty otolaryngologists, but otolaryngologists who work in a cancer program, who work in a chronic care center, things like that. That kind of division is creating complexity that is not necessarily, it might be effective in a sense, but is not necessarily effective as a totality. Well, I said, okay, what has happened to the docs? If they're doing these different things, what is happening to their sense of self? Well, I read in the News and Observer over Christmas break. That's what students used to have. Of course, I was working with the ratio of primary care physicians to the population had declined precipitously from 2010 to 2011. Therefore, we couldn't implement Medicaid expansion because there wouldn't be enough doctors. And I read that and it said, according to data from the Shep Center. And I went, oh, damn. And realized that, well, what the North Carolina Medical Board had done was change the way doctors classify themselves. They decided that the North Carolina Medical Board wanted to know what doctors are really doing, so they changed the classification from your specialty to your area of practice. It included things like hospitalists, new generalists, I'm calling them. Because I don't think the supply of primary care physicians went down in North Carolina against population. I think that some new things, people got the option to select new things, like being a hospitalist, or being an urgent care physician, or being an integrative medicine. There's still some of them growing. Student health. I mean, isn't that a generalist thing? Aren't these primary care? I think everybody would consider this is primary care. Now, and to give a little behind it, 73% of hospitals have a single board board certification in general internal medicine. 15% in family medicine. These are almost entirely people who would be considered primary care folks, but they're working in a different setting. 7% or 6% for pediatrics, only 7% in some sort of subspecialties. So we got generalists calling themselves something else. What are they doing primary care? Well, people might want to argue over that, but if I add in just a few of those 4 generalist types, we get a little bump up. It isn't bad. I can write an editorial or a letter responding to the editorial in the News and Observer. But really, the situation when we look at those people who have a generalist qualification and are practicing in a generalist setting and classified as such by the Centers for Medicare and Medicaid Services, next to God, we get this. You know, not only do we have more generalists, more primary care practitioners, we have vigorous growth to where they're going to become almost half. I hope you can see those things, unfortunately. But count those lines and see that the NPI in those specifications that are called primary care finds that we are doing just fine, thank you. So how do we communicate this complexity to people? People got used to the notion of primary care. It's in law. It's in law in the North Carolina General Assembly. It's something that people feel they understand. But then when we complexify this problem with these new types of folks or new types of classifications, we end up with a problem. So, but we're recognizing the complexity of the system and creating a policy problem for ourselves. So these hip doctors, really hip, hospitalists, intensivists, and proceduralists, are they going to be able to something that seen as the thing that is hindering ACOs because they're crushing primary care, or are they becoming an expansion and elaboration of primary care? Because if enough of these folks become that type of practitioner, then primary care might disappear as a term. When I think it was useful then, it might be useful now. So we have to do a little defense work on primary care. Primary care might become acosified. It just might drift on up into a complex nation of ACOs. So even in the primary care world, they're worried about this. Except the jeopardy, fragility, perversity, they call it avoidance, attraction, and pressure. And this is from some folks who are sympathetic to primary care, talking about it in academic medicine. Because they see real problems that are reflecting back on those people who are going into medicine. Because they see primary care as complexified by this, and if I'm that complex, I might as well do a subspecialty. But then there might be, I talked about a new kind of primary care, there might be other kinds of primary care that express themselves in other ways. So I'm going to talk about primary care in the context of variations in care. I'm going to bring in a little theological argument right here. I want to end with a benediction, of course. So I have a deity here of my own, David Goodman, good friend, pediatrician, but he's one of the people who works up in Dartmouth, drinks the water there, and but when people talk about a workforce crisis, this thing about primary care, going down in these charts and graphs, and we have a shortage of primary care. David Goodman is one of those people who says, well, we have a problem of distribution. We have a problem of how people express themselves in primary care. And that's it's an interesting point of view, which is not accepted by all. The Dartmouth Atlas debate went on, and still going on for quite some time, about what is the best way to structure a healthcare system. Well, here's the graph. This is the slam dunk graph. It basically says if you have more GPs per 10,000 GPs, is how there was an economist who wrote this and called them GPs, but they meant primary care. The more you have means more lower costs. So this is a graph that says the general practitioners, primary care per 10,000 population, and up here is the Medicare per Medicare beneficiary costs. And boy, the more of these primary care docs, the lower cost. Bingo, primary care is good. Okay, and that's essentially, this is footnoted wildly as being absolute proof that primary care is good. But we'll look at that chart a little bit later. But this is embedded deeply into our new theological text called the Dartmouth Atlas of Healthcare. He illustrated about it. Because behind this, our Dartmouth Atlas of Healthcare showing the variation, the expression of policy that came out of that was a notion of, gee whiz, we've got to get the workforce right, because that's how these variations can be suppressed when they're bad. And then you better believe that, or you will be excommunicated. Now this became something of a war of religion, because there was some people who were the equal and opposite PhD types. But this workforce policy wasn't strictly theological. I kind of take it to the civil conflicts in Britain that had undertones of religion. So I did a presentation in front of the two people you're going to see on the next slide called How Workforce Policy Became Blood Sport in the United States. And it contrasted Buzz Cooper, a friend, I suppose, who writes tends to break ankles these days. Maybe good now. And this kind of conflict, they used to share, they don't share a platform anymore. Because there's great contention between the two of them about this. And there still remains great contention about, do we have enough doctors? Are they of the right kind? Are they in the right place? But these days we've modernized the debate. We've brought in all locals. We've got Atul Grover with the AAMC talking about there is an absolute shortage of physicians in the United States. And we have a projection that suggests that there is doom on its way. And you can see this. You can go to a website and they will show you this. But we've got Aaron Frere and myself and others. So hold on. Let's look. We've got actually a way to look at this and some, options the way you would fix a shortage, if there was one, fix a shortage by the types of care that people needed. And when it comes out like that, you can actually put a few people in different places and get rid of this numerical shortage. Like I say, the AAMC has gone a little bit bonkers on this. If you want to, this just came out in the last couple of days. The doctor shortage /pages.shortage. They've declared the shortage code blue, and you can get little vignettes and cartoons of people suffering because of the shortage. So there is this message over there at the end of the cartoon. We need more money. Okay, so it's about good care, right? We need more money. Well, I'm being flip about this. We do need support for graduate medical education. The Medicare program is a reasonable way to do it. But we're not necessarily saying this to increase absolutely the number of dermatologists. It is what we have to think about it in a different way. We don't need more money, we need more direction. And Erwin will go on about that at length if you want. Now, you go on effectively about that. I'm going on. Well, what we have is to do more about projections because AAMC had a model, we've got a model, everybody's got a model. And, so we've got this war of projections. But, projections are not meant to predict the future. They're not meant to predict the future. They're intended to disturb things. This is this upward curve and then a collapse of the population of physicians exploding over the city. That's a rough approximation of Congress. We're really trying to make that change their policy. So if we give them projections that say, look, this is what will happen if you don't do this change, then they have, then they're going to change that projection. Projections are intended to be wrong. But then we always get beat about the head when say, well, your projections are wrong. What does that mean? You'll never be right. Well, of course I'll never be right. I'm trying to get you to change. And most people will change. They probably are hearing the siren call of shortage, and they're going to change things. Again, the question is, can we influence this change in the right direction by pointing out the options that change will have, by pointing out that there isn't one single projection. There are multiple realities that we could face based on multiple decisions. Well, let me go back to primary care and how good it is. Since I had nothing to do over the weekend, I updated that graph with 2013 data, and damn if it doesn't show the same sort of thing. I have a stunning straight line, and everybody goes, wow, that's an R-square, that's really short. But the R-square turned out of this data, just like the old one, was about 0.7. So it's a slam dunk, but a 7% slam dunk when it comes to costs. But primary care is getting to be something of a significant slam dunk. That's statistical talk, descriptive statistic, with an R-square of 0.20. Wow, maybe primary care does have something to do with, people dying. That's a cool thing about it. So let's think more about what this is than what the prior problem was. Now, I did some work with Mark Holmes. Mark Holmes was a very creative economist, and with Randy Randolph, and we tried to deal with this problem. Okay, what's the relationship of primary care to mortality in little places? Not just the big smear, the big, straight line. And we took all these little areas, these counties of the United States, and ran the regression and applied the local residual and all kinds of other kinds of statistics and math. Sophisticated analysis. And this is the raw correlation. So we're looking at, wow, the more primary care doctors, the lower the mortality. And it has a very big effect in that place, the purple places up there, and kind of a negative effect in these other yellow and orange. But wow, overall, More primary care means lower mortality. The little dots are where the relationship is statistically significant. A brilliant overlay of the map, credit to both Mark and to Randy. Said, okay, well that's great. Let's throw in some things like income, education, unemployment, even rurality or access to care. See what the map does. Ooh. What does it mean when more primary care is higher mortality? What does that mean? And it ain't just Florida. I mean, Sunbelt states or something? No, I mean, you're talking the Intermountain West and things like that. What does it mean when we have this kind of relationship? So we have this very complex relationship between primary care, what we want to do in medical homes, but we might be intensifying some negative things in some places. Fascinating, fascinating. Well, let's look at this as primary care, but let's look at specialists. You know, if we look at specialist supply, specialists are bad on the East Coast, they're good around Mayo, right? But you can't do just primary care without doing the specialists. That's an old adage in my mind. If I take the data and then say, okay, well, I was working for the American College of Surgeons and said, wow, let's look at what surgeons do. Well, all specialists up there had higher costs, as I'm going back to costs rather than mortality. But general surgeons, they had actually a fitted line that came out statistically significant, saying more general surgeons meant lower costs. And actually, I don't have the slide, but they're lower mortality. There are different kinds of specialists, different kinds of primary care. So if we're going to do this kind of cossification, ACO stuff, we're going to do primary care medical homes on the basis of just throwing more primary care at them or more complex systems, we need to think about what is going to happen in the aggregate on this, because there are some difficult situations that are going to arise if we intensify something that is already bad, because it's already bad in a location, and the translation of the organizational solution in that location might be a bad thing rather than a good thing. So here's again updating things over the weekend, wanting to bring news. This was 2013 in primary care. The old one was actually 2006. And we see this fascinating relationship between primary care supply, this is primary care docs per 10,000, and the crude death rate. Sorry it isn't adjusted, but it still looks, with a rough adjustment, it still looks about the same. But this fascinating relationship that is centered in the Appalachians, and then this, coastal down into, what does coastal New York, New Jersey have to do with this part of the Southeast? It's kind of fascinating. But what this says is there are even more complexity in the application of solutions, and we have to understand that a little bit more before we cause bad rather than cause good by promoting policies that might favor primary care medical homes of one style, but that work differently in different places, or ACOs that work in different places. So I I hope that meant something. But I'm coming to the end. I know there was sort of a jumble, but they said, well, it's on April Fool's Day, and I said, well, that's really a joke. But so I wrote this all last night. But no, I do want to thank Gordon for what he's allowed me to wander off into philosophy, wander off into data. People like Harvey Estes, who will be 90 years old pretty soon, and those people are, they were so inspirational to me. I hope that there are people, and I hope to have been one of those people to inspire other people to doing these kinds of things. But I do want to thank one person most of all, and that is the kindest critic, my wife. She's in the red, so you'll notice. She has made all of this possible. I'm sitting in our house writing a dissertation. She helped me do all of this, and I really appreciate it. And thank you very much, Diana, for doing all this, making things happen, making change. So thank you all. I hope I've given you something to think about, and I hope that talk does right now. maturity thesis right here. I mean, the unintended consequences is the jeopardy part. We've got to understand them on the pro side of change as well as on the negative side of change. And just having, I mean, okay, that's great. I said that, say Albert Hirschman, they'll figure it out. No. But yeah, we have to have structures for that. It's fascinating now that all of these demonstrations and implementation programs and things like that do not have tightly linked evaluations that are tied to a policy solution. Health services research back in the good old days had the RAM health insurance experiment, which is looking at some big things, but it wasn't necessarily tied to a big policy decision. The Rural Primary Care Evaluation Project was something that was funded by Robert Wood Johnson and the Office of the Assistant Secretary for Health, and it was supposed to be tied to some policy things. It wasn't. We are one of the few developed nations that doesn't have the policy process doesn't go like this. We will set up a program, and in 5 years we will assess whether that program meets these goals, and if it doesn't, it's out or it's disseminated. That sounds logical, but we don't do that. So, and there are all kinds of, and I think John Overlander will explain that. So, I mean, I wish it were. This is where we have the change part, but where we have to manage change. We have to kind of push people for when we have a bright idea. It's fascinating. Health services researchers consider you get a badge if you propose something new, but you don't get a badge if you evaluate it and show that it might be better adjusted. So we don't need instances of that. No, we need it. Oh, stunned in silence. Oh,
So you're saying that we need to anticipate that perversity. We know that your enemies, and you do have enemies in this field, you're not just throwing it out to the world, but your enemies are going to take that, whatever data you get, and seek a way to make it look like, oh my gosh, you're never going to get in to see your cardiologist. So you have to somehow anticipate that perversity. Is that what you're...
Yeah, it's a pretty simple thing. I mean, it's hard. It's just a question of not being surprised by when people come up with a logical, antithetical argument.
Right.
You know, you should think about that beforehand and have that figured out at the beginning. I mean, and it's a political thing of trying to, immunizing yourself against whatever your problem was. That first came up with Kennedy. Kennedy had a problem with women, and they had to immunize the press about that. Sorry, that's what it is. No, I mean, you
Next
heard.
Is there a country that's an exemplar in testing the change, putting things out there, testing, and either deciding to stop or disseminate?
You can point to England saying they do have some assessment, but all they do is just have sequential change. France actually has a system where they did create tightly linked institutions that are related to evaluation and assessment. And so they have an entire evaluation and assessment structure that has a quasi-legislative ability to change payments and change some of the structures of things. They're given the ability to change the law. Now they're doing this, they did a big, ordinance here, and I'll tell the story. They created, in 2005, there was a big heat wave in France. A lot of old people died because everybody was on vacation. It was a national disgrace. And they decided to get rid of one national holiday, take the estimated gross domestic product of that, put it into a Ministry of Autonomy, meaning autonomy for elderly people, and to create experiments that had time-limited assessments to see whether they would be distributed through the system. They did the same thing in primary care, where they created called Prosper, a test of multi-professional organisms. Now, there's a French person in the audience who's going to challenge me on this to some degree, but they're doing these experiments, and then the question is whether they will implement them broadly. Now, they declared a victory in the primary care team stuff, the interdisciplinary teams, and the minister has said, said that's how the future was going to be. That's a little bit like us, accepting ACOs as the next best thing. But at least they did do an experiment first and then determine what the elaboration would be. They have not yet completely made them generalized. Is that right, Lucy? How am I doing? Right. Yes?
I'm curious if the figures you had in the beginning about research, policy, and politics and the interaction of those three things. A lot of the conversation is about the problems that we have because politics is not necessarily a good faith debate about policy. And I'm curious to hear you talk about what you think that does to research. Does it change the way you do research, what you think the imperatives are there, what the goals are there?
Well, I mean, the example was the news and observer thing. Okay, you put out some data and somebody takes it and says, okay, Medicaid shouldn't be expanded in North Carolina, And you feel really bad because you didn't anticipate. Well, I had anticipated that. In fact, I fussed about it. And you said, this is going to, something like this is going to happen. But you've got to be prepared when it happens. Because you got to, when somebody comes out with, silly extension of research results, conclusion number 4, you've got to have written the response to that right away. And in the process of politics, you have to respond immediately. When you have crises, you have to respond immediately. You have to not let it build into some sort of mentality that this is really what happened as opposed to what they say is happening. So we have to prepare when we change, when you see change happening in, say, the compliance with medical homes, when the early adopters, have all done it and then the adoption rate is going down, you have to anticipate and show that that's what we expected. So it's just being prepared with your own understanding of what the data mean and what the data mean over time. Because unfortunately, you'll be better said in the future than what it used to be, but it's coming.